Hi, this is Professor Nicholson lecturing on applying the nursing process to patients with elimination needs. This lecture is specific to Unit 7, Module 3, Urinary Elimination Needs. Please review the sub-competencies for Unit 7, Module 3 on your own. Please familiarize yourself with these common terminology terms. There are many colloquial terms regarding urinary elimination. Therefore, you need to use familiar language with your patients. Be careful with your terms to be sure they are understanding. Factors affecting urinary elimination. So, developmentally, at around 2 years old, neurolinks are established between the micturition center in the spinal cord and the cerebral cortex. Voluntary control begins to develop as well. Elderly patients, prostate hypertrophy, decreased muscle tone, loss of bladder elasticity, kidney function decrease, urgency frequency, these are all common. Nocturia and incomplete emptying is also common in this population. Regarding nocturia, this is when patients frequently urinate over the nighttime, so you want to make sure you encourage limited fluid intake after dinner to avoid this. Urgency, make sure your patients know the locations of restrooms. And then in regards to pregnancy patients, which we'll talk about in the spring, just keep in mind that they may need to urinate more frequently due to pressure on their bladder from the growing fetus. In regards to nutrition, caffeine causes diuresis, alcohol increases water loss via the urine, and excess sodium contributes to fluid retention. In regards to hydration status, you need to monitor their intake and output. Urine concentration reflects hydration as the body balances its fluid needs. Many people who have alterations in elimination do not hydrate adequately to avoid having to urinate. More factors. So physiologically, anxiety and stress can increase frequency and urgency or can make it difficult to relax the abdominal, perineal muscles, as well as the sphincter muscles. It's important to provide privacy, but also ensure patient safety. Culturally, this includes the degree of privacy, the acceptability of discussing elimination, as well as any health beliefs about what is normal. Sometimes this is what prevents people from seeking care. Keep in mind the patient's ability to talk to the care provider, such as those of opposite gender. Regarding hygiene, you need to understand your patient's routine. For example, in India, they use bidets and avoid toilet paper. Pain can also limit the ability to void, as well as medications. These can cause urinary retention, incontinence, as well as changing color of urine, depending on the medication, of course. Anesthetics, especially regional anesthesia, can also cause urinary retention. You need to know how to promote normal urination. So adequate hydration is what flushes bacteria and keeps urine dilute. With nocturia, you may need to limit fluids after dinner. You need to facilitate their toileting routines. Identify the patient's pattern. Do they need to go every few hours? Answer call bells promptly. And also ensure privacy as we performed during that cleansim with the bedpans. Stimulate the voiding reflex. The sound of running water may help. Putting hands underwater, pouring warm water over the perineal area could help. I've had patients be able to void successfully just from the smell of peppermint. You want to assist them with their positioning, especially after they've discontinued an indwelling catheter. Remember, safety takes priority. Men stand, women are seated upright. Like I mentioned, provide relaxation techniques. Make the patient comfortable. The following are bladder numbers. Normal bladder capacity is 300 to 500 milliliters. The urge to void begins around 150 to 200 milliliters, and normal post-void residual is less than 50 milliliters. Common tests include a urinalysis. This is a screening tool, and results are available rather quickly, so within hours, and these provide non-specific results. A urine culture and sensitivity is a diagnostic tool. Cultures take about 24 to 48 hours, and the sensitivity may take even longer. These provide more specific results, especially from a sterile specimen. Please know normal urinalysis lab values. So what is specific gravity? This compares the density of urine to the density of water. As mentioned, normal urine is about 1.001 to 1.029. That's the specific gravity lab result. High values indicate concentrated urine, as this occurs in dehydration. The higher, the drier. So the higher the value for specific gravity, the drier. Low values indicate dilute urine, as this occurs in overhydration. Within normal values, trends indicate the direction of concentration. Again, high values indicate concentrated urine, as occurs in dehydration. So the higher the value, the drier. The low values indicate dilute urine, as this occurs in overhydration. Diving a little deeper into urine culture and sensitivity. This is a urine culture that determines the presence of pathogens. The sensitivity portion is when pathogens are present, and it identifies antibiotics that are effective against the pathogen. Normal results mean there is no growth, and abnormal results are greater than 100,000 milliliters of one pathogen. Intermediate results often indicate contamination but may be significant. The following slides are going to go over urine specimen collection. A random collection, as I mentioned in the previous slide, this is for urinalysis. It's done by dipstick or in the lab. It can be a clean specimen cup, it can be a specimen collection, so voided from a cath port or diversion collection bag. This is not collected from the catheter drainage bag. Clean voided specimens. A clean catch is a midstream catch. This is for urinalysis and culture and sensitivities. It's a sterile specimen cup, and to do the specimen collection, you need to ensure the patient cleans the meatus with 3 wipes, not in circular motions. Collect the midstream specimen. You want to minimize contamination, such as do not touch the inside of the cup. Timed urine collections measures the amount of specific substances, such as hormones, protein, and creatinine. It needs to be in a clean container. All urine collected for a given time period begins after urination and ends with a final void at the end of the time period. So it's a 24-hour collection. That's really the most common type. Checkpoint. Which value indicates the patient is overhydrated? Keyword, overhydrated. Remember your normal urine specific gravity range. As I look at this, I can automatically deduct A as well as C. Why? Because these fall within the normal range of urine specific gravity. When I look at B, I can see that this is a higher value. So remember, the higher the drier. So this would indicate dehydration, not overhydration. So the answer here would be D, because 1.000 falls below the normal range for the urine specific gravity. This one would indicate diluted urine, as this occurs in overhydration. Next, we are going to talk about pathological conditions. Cystitis. Itis really means inflammation, but most of the time infection is the cause, so the term is generally accepted to mean infectious inflammation. Interstitial cystitis refers to non-infectious cystitis. You got to know that bladder infections are much more common than kidney infections. So going off of this, the source is usually rectal contamination, vaginal contamination, as well as urinary retention. Symptoms are usually local. Local means the site of the infection. So where is that infection? These symptoms include dysuria, frequency, urgency, hematuria, as well as cloudy urine. Notice how those all come from the source or the site of the infection. Frequency, you need to make sure you ask about pain and the color of their urine. You need to know that. Again, frequency, you need to ask the patient about their pain and the color of their urine. In regard to elderly patients, sudden onset of mental status changes is a very common symptom. Treatment for cystitis are antibiotics, and complications are generally pyelonephritis, sepsis, as well as scarring. Pyelonephritis. 90% of the cause of this is due to E. coli bacteria. This is a kidney infection, but it can coexist with the bladder. The source is usually an ascending bladder infection. Symptoms are flank pain, fever, hematuria, pyuria, nausea, vomiting, as well as sudden onset confusion in elderly. Treatment are antibiotics, and complications include kidney damage as well as sepsis. Again, if you are unfamiliar with any of the terms within these slides, please take time to look these up now. The following are risk factors for UTI. UTI can be caused by a kidney or bladder infection. Women have a shorter urethra, and their urethra proximity to the anus is shorter, so they actually have an increased risk for infection. Also keep in mind intercourse and perineal hygiene related to mobility issues can also be factors. Men have longer urethras, and prostatic secretions contain an antibacterial substance, but it's still possible for them to get an ACI. In regard to invasive procedures, this includes catheters, such as indwelling catheters, as well as straight catheters, as well as IV lines and surgery. Blockage is also a risk factor, so this could include the prostate, any stones, as well as a kinked indwelling catheter. Regarding urinary stasis, the urine becomes more alkaline, which promotes microorganism growth. The urine becomes cloudy because of the increased white blood cell count. Prevention of UTIs. Fluid intake. This dilutes and flushes out bacteria. Also, cranberry juice. This helps acidify urine. This is evidence inconclusive, however, it's not harmful. You need to make sure your patients avoid fecal contamination near their urethra. This includes females wiping from front to back, and promptly change diapers or adult incontinence products. Make sure patients void frequently and avoid urinary stasis, and make sure you educate your patients to void after intercourse. Diagnosis and treatment of UTIs. Empiric antibiotic treatment is usually started based on urinary analysis results. Regarding empiric treatment, this is an initiation of treatment prior to having complete knowledge of the best treatment, and it's based on an educated guess on the provider's side. But it's just getting the patient started on treatment. The culture and sensitivity results may necessitate change in antibiotic regimen. So once the provider has a better understanding based off of this result, they can change that antibiotic to best fit the patient's need. And test of cure. Reculture after the course of antibiotics to confirm adequate treatment. This is done in select circumstances. Catheter-associated UTI, also known as CAUTI. 75% of UTIs in hospitals are associated with the use of an indwelling catheter. This can be caused by contamination during insertion, contamination via the drainage bag, as well as urinary stasis. The longer a catheter remains in place, the higher the risk of UTI. Many facilities try to implement straight catheters, as evidence-based research has shown this decreases that UTI risk. Why? With indwelling catheters, there is a chance of biofilm. Biofilm is a complex compound of proteins, electrolytes, and other organic matter that accrues on indwelling devices. Bacteria and yeasts attach firmly to the biofilm and multiply rapidly, creating a slime. Tooth plaque is an example of a biofilm. Nurse-driven protocols. You need to know this. You should only insert a urinary catheter when necessary and with a provider order. You want to make sure you use sterile insertion techniques. You will go over this as your spring semester approaches. You want to prevent backflow, so always make sure that that catheter stays below the level of the patient's bladder. You want to ensure that the catheter is patent. You want to avoid any kinks. You want to ensure you have a closed system, so do not disconnect the spout unless you need to, such as when you're emptying the bag. You want to avoid contamination of the spout, and you don't ever want to empty the bag more than necessary. But of course, you're going to empty it if you notice that it is on the fuller side. Trauma. After inflating the balloon in the bladder, you need to make sure you secure the catheter with a stat lock, is what we typically use, to the patient's thigh. You want to do this so that there's no traction and you don't want to cause trauma to the urethra. Also, if you're ever removing a urinary catheter, make sure you deflate the balloon before you tug out that catheter. Regarding hygiene, make sure that you use soap and water daily, especially after each bowel movement. And last but not least, you need to make sure you encourage fluid intake, because remember, fluids help dilute the urine. Urinary incontinence. This is the involuntary loss of urine. This is underreported by patients. Your priority assessment, you need to know, is to assess the condition of the skin. You would also ensure you help assist the patient clean themselves up right away. You would never leave a patient like this. Urinary incontinence is not an inevitable part of aging. There are types of incontinence. So there's functional, so not related to urinary system. This can include mobility, cognition, as well as communication. There's also reflex. This is neurological. This can include paralysis and MS. There's also overflow. So there's no urge to void, the bladder fills, and pressure exceeds the sphincter ability, and the bladder does not empty entirely. There's also stress, so the loss of urine associated with increased abdominal pressure, such as coughing, sneezing, and laughing. And lastly, urge. This is a sudden severe urge to void. Adult urinary incontinence implications include skin breakdown, altered body image, social isolation, low self-esteem, falls, as well as economics. It's very important to know urinary incontinence interventions. You need to prevent skin breakdown by keeping the area dry and clean. You need to utilize absorbent products, but change them immediately when soiled, and utilize barrier creams. You want to encourage hydration as some patients have a tendency to avoid liquids because they want to avoid incontinence. Not being very well hydrated actually increases concentration of urine, which increases that risk of skin breakdown when incontinent. Ammonia and urea are very irritating. This also increases the risk of UTI, as we've mentioned in prior slides. Habit training. Patients need to schedule voiding times around their pattern of incontinence. Self-catheterization, for instance, neuroincontinence patients. Condom catheters. You want to avoid indwelling catheters just for convenience, except for cases of skin breakdown or end of life. Again, catheters need a provider order, especially those indwelling ones. Bladder retraining. Practice holding. Make sure your patient has a goal to reduce their frequency. Kegel exercises and the Knack maneuver. This is a rapid series of pelvic floor contractions. This helps trains those muscles to help with urinary incontinence. And then you have medication or surgery in some cases. Urinary retention. This is the inability of the bladder to completely empty. This can be caused by anesthesia, medications, and obstruction such as enlarged prostate, trauma such as infection or childbirth, neurological deficits, as well as post-Foley catheter removal, post-void residual by bladder scanner, or straight catheter is less than 50 milliliters. You will see a picture of a bladder scanner on another slide. If the bladder continues to fill, the patient could be experiencing overflow incontinence. This is when a small amount of urine leaks out frequently, but the bladder does not empty fully. Also, this could be caused by ureteral reflux and can lead to pyelonephritis. Stagnant urine becomes alkaline, as we've mentioned, and this makes a patient prone to infection. Urinary retention. Signs and symptoms include bladder distension, suprapubic pain or pressure, small frequent voids, dribbling, absence of urine output, and post-void residual being 50 to 100 milliliters. Note that that is different than post-void residual via the bladder scanner, as mentioned in my previous slide. Interventions include correcting that cause, evaluating the bladder, and catheterize only as ordered. A distended bladder assessment includes palpation as well as a bladder scan. Assessment of residual urine. This is after the patient spontaneously voids. Know again, normal post-void residual is less than 50 milliliters. Method number 1 is a bladder scan. This is non-invasive. The second method, as I've mentioned previously, is to cath for residual. Again, you need to have an order for this. You need to perform the straight catheter, measure the amount of urine remaining in the bladder. Order may read, if greater than X milliliters, leave catheter in place. Use Foley rather than straight catheter in this case. So again, make sure you read your orders carefully before you remove that catheter. Urinary diversion. This is a surgical redirection of urine flow to empty via the abdomen. This may be temporary. Urinary diversion is done when the normal flow of urine is blocked or the bladder can't store anymore. Issues include infection and also, if permanent, lifestyle changes such as body image, sexuality, self-care management, as well as skin care. Interventions include teaching, ostomy support groups, ostomy nurses, as well as meticulous skin care. Nursing process related to urinary elimination. Assessment includes sensitivity to cultural and psychosocial factors. Obtaining a detailed nursing history. What's the patient's voiding pattern? Do they have pain, nocturia, incontinence, emotional effects, etc.? Monitor intake and output. Normal intake should approximately be the same as output. Assess for urine characteristics. What's the color, clarity, and odor? What's the volume per void? And do a physical examination. Obtain vital signs. Do a CVAT assessment. Palpate the bladder. You should feel if there's a swelling above the pubic bone. If there is, that means bladder swelling. Scanning the bladder, looking for residual urine, as well as conducting a skin assessment. And of course, knowing your lab interpretations. So knowing if you need to collect a urinalysis or a culture and sensitivity, or if they've had one done, assess these labs. The following are nursing diagnoses related to alterations in urinary elimination. Interventions and education are appropriate based upon the diagnosis. Checkpoint. Your patient had surgery yesterday. Today he is complaining of discomfort with urinating and only voiding a small amount each time he goes to the bathroom. Based on the nursing process, what do you do first? So in this case, you're going to inspect for bladder distension. Please review the following slides on your own.